Good evening, everyone. Thank you so much for taking our time and joining us today for another session of Child Mental Health Community of Practice. And the topic for today is gender diversity. We would like to formally start our session by acknowledgement of country. Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, Boon Wurrung people, and the Wadawurrung people. We pay respects to elders past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Just some community of practice guidelines for people who are joining us for the first time. So please stay on mute unless speaking, raise your hand to speak, keep conversations confidential. If possible, we would appreciate if you could keep your camera on. Introduce yourself and your role as well, since we are a diverse community of practitioners. Share ideas and promote everyone's participation, and acknowledge that we have varied learning needs and interests. And please feel free to ask any question. Another important point is that please ask the questions during the educational component via the chat box, and this session is being recorded. So if you are joining the session using the correct name that you registered with, that's the only way we can mark your attendance, as certificates and CPD will not be issued if we cannot confirm your attendance. Just for some pointers for someone who is not very comfortable with technology like me. So if you want to change your name in your Zoom meeting, please, if you're joining via app, click on your name. And if you're joining via desktop, just hover over your name and click the three dots. And if you're joining by Mac, then hover over your name and click more, click on rename, and you're good to go. We have Dr. Prakash, who is our consultant psychiatrist. He's a senior consultant child and adolescent psychiatrist at RCH with over 20 years experience. Prakash has worked in and managed general and specialist clinics within child psychiatry in metropolitan and regional public mental health services. He has worked with children and adolescents from 4 to 18 years of age, assessing and managing a variety of mental health issues. I'm Saha, and I have been a GP at Gunawara. My areas of interest are child and adolescent mental health and chronic disease management. And Tram has kindly joined us today. She's a psychiatrist and mental health lead at RCH Gender Service. Tram has had a breadth of experience working with young people and their families. She's a strong advocate for those who are vulnerable and marginalized. She's excited and privileged by the opportunity to work with young gender diverse people and their families through the journey at the Gender Services. Just a quick look at the agenda, and after that, I'm going to request Tram kindly to present the education component. Over to you, Tram.
Thank you.
Would you prefer sharing your own screen?
No, I didn't set mine up because I thought you would have
I'm more
yours.
than happy to do it. Just give me 1 sec. I shouldn't have stopped sharing. Oh, good.
I guess the question is, can I actually click through?
Not really, then you'll have to, I think I'll have to click for you if I have it on, otherwise you'll have to share yours.
Okay, that's what I thought. Oh, that's what I was asking about, whether or not I could actually click through myself.
So do you want to share yours? I'll stop sharing.
Oh, I haven't got mine on the screen because
Okay.
I have mine on it. I haven't opened it up into this computer.
Okay, I will try my best to facilitate you. Just let me know.
Okay. So thank you. So I'm Dr. Tram Nguyen and I'm a psychiatrist with the Gender Service, and I've been there for about 7 years. And go to the next slide. And so I'd like to also acknowledge the land in which we meet, and really acknowledge that the Wurundjeri people of the Kulin Nation, and acknowledge their strength, resilience and capacity, and pay my respects to elders past, present, and those who are with us in the room today, and really acknowledge that the impact of colonisation on Aboriginal and Torres Strait Islander sister girls, brother boys, and the people of traditional diverse genders of First Nations of Australia. And I'll speak more to this in a later slide as well. So first up, I'd also like to acknowledge that I'm a cisgendered woman here speaking, and that's my privilege. And so I do try and incorporate feedback from trans folk and people who've been in the audience with me, because I really like to embody the nothing about us without us, and always trying to hear what those who are trans and in the trans community have to say about how we present the education that we do. Next slide. So I've got a lot of slides and I've put them all in hoping, what can we get through? Because I do want to be able to give you a lot of content. So first up, just around numbers. So for those of you who've been following the news, there's been a little bit of debate around the census and whether to include gender identity and sexuality as part of it, and how to word it. And this is a really important piece, because unless we actually ask the questions, we actually don't know how many trans and gender diverse people are in the population. And so these are the two recent surveys of young people. So the La Trobe one is year 10 to year 12, and the Mission Australia one is, I think it was age 14 to 25, something like that. So large responses. And so the prevalence, they think, from these surveys is 2.3 to 3.7%. I actually think it's a lot, it's higher than this. And when I started in the job about 7 years ago, we were told it was like 0.5. So there's actually a lot of underreporting. And for those who are working within Victorian health-funded organisations, starting, I think, soon, there will be compulsory asking of people's sex assigned at birth and their gender identity. So it comes as part of the forms that people fill in addition to things like religion or whether someone's Aboriginal or Torres Strait Islander people. So this is adding on to the collection of data that the Department of Health in Victoria will collect. Okay, next slide. And so this is some of what I alluded to around First Nations cultures. So this is the World Gender Customs Map, and it's actually an interactive map. So when you put this into Google, you'll get an interactive map that you can move about, you can expand and enlarge. And when you click on one of the blue pins, what you get is the history of gender diversity within that region. And so we do have one in Australia, and for a while, the Tiwi Islands was the largest proportion of population of people, trans and gender diverse people in the world. And that's just one of the islands off Australia, with lots of brother boys and sister girls. And so what you'll notice also here is that there isn't a blue pin over the United Kingdom or parts of Scandinavia, France, Germany, and Europe, and they're the ones who've colonized most of the world. So a lot of what we know about gender diversity as being part of human existence for hundreds and thousands of years has been lost through colonization and sort of that erasure of history as well. Okay, next slide. So I've got some slides on terminology, and even though some of it might be obvious, it's really important because a lot of the terminology has been used in the media in a way that confuses people deliberately, sometimes for misinformation. So the media might have you say that sex is really obvious, and we often speak of sex assigned at birth. But there is no one definition of sex. It's a combination of physical characteristics, genetics, and it might be XX or XY, but that doesn't always align. And those in primary care will know, medical professionals know, that doesn't always align with what your genitals are, and that 1 in 100 people are intersex. So when you say someone's sex, in the olden days, it would be, when the midwife or obstetrician holds up a baby and it's on physical characteristics. But now we do genetic testing prenatally. And so that gives us it might give us a different answer to what sex is. So it's not, there's not one agreed on single definition. Sexuality is how, sorry, if we go back one, the feelings that you might have towards another. And it is mostly interpersonal, but I think sexuality and your sense of attraction to others actually resides within oneself. So whether someone is lesbian, gay, heterosexual, pansexual, or actually asexual, we're seeing a lot more people identify as asexual if we ask the questions. Whereas gender is totally different. Gender is not about someone else. Gender is about an internal feeling you feel of oneself as either male or female, non-binary, or along the gender spectrum. And it's mostly personal. And I say that because sometimes we only notice our gender when we're in interactions with another. So I feel most female when I'm in a room with men because I've noticed my difference, whereas gender might not come into my thoughts when I'm just around a mixed group of people, say, or a group of mainly female identifying people. And where the confusion comes in is when the words male and female are used for both sex and gender. So it means like, what are we talking about? Are you talking about female sex or female gender? And that's where some of the confusion might come into play and why I bring up this slide around terminology. Okay, next slide. So some of the language that we use is, and you'll see in some of the old literature as well, assumed male at birth or assigned male at birth, assigned female at birth. And the reason why we do this sometimes is to know what potential anatomical features someone might have and what kind of treatment they might want in terms of hormones, particularly if they're identifying as non-binary. A cisgendered person is like myself, whose gender identity aligns with my sex assigned at birth, whereas trans or transgender is someone whose gender identity is not congruent with their sex assigned at birth. Some people include non-binary under that. Some people see non-binary as separate, and usually I just go with whatever people, the person is identifying with. So non-binary is someone who doesn't identify as exclusively male or female, and someone who is gender fluid is someone whose gender identity might vary over time. And so for some people, they say, I don't have a name or a label for my gender. Next slide. And so ask a young person in terms of what they use or don't use and check what they use. And this is a quote from a 9-year-old who's given their perspective. And sometimes people don't have pronouns as well. So some people say, don't use pronouns. I just want my name used because I don't identify as any of the pronouns that are out there. Okay, next slide. And I think this is the last slide on definitions. So gender non-conforming or gender expansive doesn't mean that someone's transgender. It's a big umbrella term for people who don't conform to society or culture's binary expectations of male and female. I've brought back here gender identity to separate it from gender expression. So gender identity is what you feel on the inside, and gender expression is what you might look like on the outside in terms of your name, clothing, hairstyle, voice, mannerisms. And so someone's gender expression doesn't necessarily have to align with their gender identity. So you can have someone who can look like someone, and I'm using an old term here, that community accept, a butch lesbian look, but that person could similarly be trans-masculine or non-binary. The person who's butch lesbian still identifies as female, but they might all have the same gender expression. So they don't always align. So someone who's female can be very feminine looking, which is how I prefer to present in terms of gender expression, whereas someone else might be more masculine. Okay, next slide. And this is just some of the tools that we use for young people. So we have this as an online version where people get to move the ruler as to how male they feel like now, how female, or how non-binary, what have you. And we track that with the progressive online surveys to see whether that changes. Next slide. And in the room, for those who are really young, this is something I might use, or sometimes I just draw it as a line. I have some young people who come in and they already do it. They pull out the piece of paper, they draw the lines and tell me where they are from session to session, which is really lovely as well. Next slide. And this is a graphic that you can get online freely. And actually, sometimes I actually use this more with parents of young children to explain to them what the difference is between gender identity, gender expression, whether someone is more feminine or masculine, sex assigned at birth, physical attraction, and emotional attraction. So, because sometimes parents struggle to see that difference as well. So we might do this activity where everyone does it in the family. Okay, next slide. So a point I have here, and it's a point around what you do when someone presents clinically, a young person, is that there's lots of people who might be gender expansive, and that's really broad, and they express themselves in ways that pushes the boundaries of culture and societal norms. What only a small percentage would be considered transgender. Those are the ones who actually say, this is how I identify, as opposed to just what they decide to wear. Next slide. And this is just an example. These two would be considered gender non-conforming, pushing the edge. And what you'll notice is that those who are assigned male, it's much easier to look like you're pushing the edge. You just wear something feminine, whereas if you're assigned female, it's okay for those who are assigned female to run around in shorts and t-shirts. And so we see this differently in the clinical situation, in the sense that early on we have more birth assigned males who are feminine presenting. Their parents get worried and we get them referred to our clinic. Then we do birth assigned females, and it's usually the birth assigned females who are referred later to us in puberty, when they actually verbalize their distress. So we have a switch of who presents more, and by adults in the adult clinics, it's usually around 50-50. Next slide. So the next couple of slides are around diagnosis, and we don't tend to use it so much because we actually think it's really pathologizing. But for those, and I'm putting it here for completeness, that the DSM-5 criteria for gender dysphoria requires that a person has at least 6 months, it's only 6 months, of at least 6 of the following, but the first criteria should be met, which is a strong desire to be of the other gender, or an insistence that one is the other gender. And then the other points are around preferences. So preferences around dress, preferences around cross-gender roles, like in make-believe, whether you play a mum or a dad, around toys, games, around who you would have as your friends, and whether you reject the other types of play, a person's reaction or dislike to their own current anatomy, sexual anatomy, and physical features. So, and of course, as with DSM, that it should be clinically associated with distress, impairment. And one of the issues we have here is a lot of those are bounded by stereotyped behaviours, and they're not actually about how, it's only the first one really is about how a person feels about themselves. And maybe I might add in the parts around anatomy, but really the rest around preferences. And what it does, it's just reinforcing gender stereotypes that say that, you know, you're more likely to be trans female just because you're assigned male and you like to play with Barbies. So it reinforces that, and it prevents, you know, boys who want to play with Barbies to playing with Barbies without causing distress amongst their parents and educators. Okay, next slide. Whereas ICD-11 moves gender incongruence, they don't have gender dysphoria, they have gender incongruence, and it's not in the mental health chapter. It's actually in the differences of sexual development. And it's really, again, a strong desire to be a different gender than the assigned sex, a dislike of anatomical features and secondary sex characteristics. And then it talks about the make-believe, the toys, the activities, the playmates. And they have a criteria of about 2 years. But they actually specify gender variant behaviour or preferences alone is not a basis for assigning the diagnosis. So when you ask the question, how do you know if a child is trans, is actually you ask them how they identify within their gender, and you see how consistent that is over time. rather than look at necessarily always what they play with. Because, and again, when you see young people who are neurodivergent, autistic, they might have very varied preferences and play, and not read the social stereotypes as strongly. Next slide. So a couple of reflections as a break. So when were you first aware of your gender identity, if you look back through time, and was there a point of that awareness? Next slide. So how do you currently embody or express your gender? So for me, at work, you'll never see me in pants. I'm always in a dress or a skirt. And that's my preference, to be very feminine in my expression and how I embody my gender. And the next one, imagine what it's like when people do not perceive your identity as you experienced it. And for me, this has only happened a couple of times, but I clearly remember when it did. And both times it was online. You put a doctor in front of my name, and people assume that I'm male. This was way before I put my pronouns in my signature. And they were both times were from women who were well-intentioned and very lovely. But I remember it. And for someone who is transgender to be misgendered all the time, I can only think about how heavy that burden weighs cumulatively. Okay, next slide. So in terms of gender development, if you think about when you first realise or had knowledge of your gender, we know that, from 2 years of age, children are aware of physical characteristics between boys or girls, and I put that in brackets. There's some evidence that maybe infants know earlier based on pitch of voice and cadence and musicality of voice. By the third birthday, most children will label their own gender and those of others, again on physical appearance and other features. And by the age of 4, I say most children will have a stable experience of their own gender identity. But it's very hard sometimes for trans kids to have that experience because they're given different messages around stereotypes. So sometimes they might feel that there's something wrong, but they might not be able to express it as clearly until they have the language for it, which comes later. And that around this age is really lovely. You can go to childcare centres and everyone's playing together. They all have their nail polish on, or they're playing. And then you see once they reach school, there's this segregation into boys and girls, and that's reinforced by teachers getting children to line up in boys and girls. So there's this nice innocent period before that. Next slide. And gender norms are continuously reinforced. Like, you imagine how many messages have you heard today that relate to some kind of gender stereotype, whether it be how you should present physically or how you should be. And I think it's just as vicious for birth-assigned males who are told to man up, don't run like a girl, boys don't cry, that kind of thing. Next slide. And just in terms of development, and this is a generalisation, that gender identities develops a lot earlier, often, than sexual orientation development. Of course, for some people who might be aware of their sexuality a lot earlier than that, and the sexual development aligns with the time of puberty. Next slide. So a really important thing, gender diversity is not a mental health disorder, and that being trans and gender diverse has been a part of human existence throughout time and history, and there's no treatment indicated or warranted for people with transgender identities in terms of mental health. So the mental health comes from things like rejection, bullying, and we know the harms of bullying, exclusion, marginalisation, negative attitudes, invalidation, denial. And it's gender dysphoria, the distress someone might have around how they experience their body, that might benefit from support and medical intervention. Next slide. And this is the Trans Pathway Study, which is a survey of mental health experiences of young people. I think it's about 900 across Australia. Next slide. And what it shows, and you can click forward as well, that the rates of depression, anxiety, eating disorder, self-harm and suicide attempt, which is a lot higher than the general population. And related to this is those factors that I mentioned before, and in the next slide. And if you click on the next part as well, so the rates of sexual harassment, physical harassment, verbal harassment, and feeling really unsafe and uncomfortable in educational settings. And okay, so how do we improve? This is what we do at the Children's. We listen. We keep clicking through. We listen. We do more listening. We do lots of listening. We empathise. We're self-aware. Be non-judgmental. Put the young person at the centre of decision-making. It doesn't mean like we're not thoughtful, but we actually always refer back to the young person and we respond to their needs. And this may include their preferred name, correct pronouns, how they'd like to present, identity documents, the medical pathways such as puberty, pubertal suppression, menstrual suppression, hormone treatment, and always family support, because we're also always, because a young person is never in isolation, hopefully. So gender affirmation, and I'll talk through the three main classifications that get often used in gender affirmation. The social one is just basically being able to live and express yourself as your authentic gender. Things like name, pronouns, hair, interests, activities, legal name on passports and birth certificates. And there might be things around accessories like binders, tuckers, padded bras, padded underwear, and how people interact with gendered spaces like toilets and camps, change rooms. Next slide. And you can slip through these, that how gendered toilets are, moving to a more gender neutral way of having toilets. Okay. Medical affirmation includes things like pubertal suppression and, as I mentioned, the androgen blockers, which for the medical people, cyproterone and spironolactone. Menstrual suppression can be through the oral contraceptive pill or through things like Primalute, and then there's estrogen and testosterone. Next slide. And so pubertal suppression is through gonadotropin releasing hormone analogues. And they were originally used for precocious puberty, just to halt the puberty and then to come off and to recommence puberty. And we see young people as puberty kicks in, there's an increasing distress of people realising that their body shape will change to the sexual characteristics that they don't identify with. So it allows for more time for gender expression and exploration. It allows time for more development, decision making. And if you're on blockers and then you use the hormones that you identify with, then you're going to have more congruence with a cisgendered type appearance. So people are less likely to know that you're trans, which some people prefer. They prefer to not have that out. The main effect is on bone mineral density, and we have yearly bone scans for all the young people coming through our service. Next slide. And surgical affirmation. So I've just listed it here, and I'll share my slides around the surgeries that are available, but none at the Children's Hospital. So this is what we do. We have a triage assessment, which is done by our nurse or one of the fellows, which is really around educational. We get pubertal status. So when you refer to us, we'll want to ascertain pubertal status, because if someone is peripubertal and we think they might be appropriate for puberty suppression, then they get fast-tracked to a shorter waiting list. We look at, in that session, there's also mental health needs and medical needs, so thinking whether there are other referrals that people might need, and some general health education. And actually we find that after that appointment, a quarter to a third of people don't progress to the next part of our service. So they decide that they're just having exploration, or they're non-binary and just are looking to think about their expression and they don't want a medical pathway. For those that do, then they continue on to our multidisciplinary assessment clinic, which includes a number of clinicians that you can see there. And there's options to have medical treatment in terms of pubertal suppression, estrogen or testosterone, and a referral to discuss surgical treatment, because we don't offer it ourselves, but we can do a referral later down the track. And I've put in there stage 1, stage 2, and stage 3. They're legal terms, but it's not terms that we use. Next slide. So this is what can happen. So someone might come, if you go back one. Yeah. So we might have someone who comes in and, like, for example, they just have pubertal suppression, and then they think, well, actually, the most common situation I have is that someone says, I'm non-binary, but actually, if I'm going to choose a puberty, I'll probably choose the puberty that I have endogenously. So they come off pubertal suppression and they don't have the other medical treatments. Next slide. This pathway is, for instance, who's someone who might come in later to our clinic, who's post pubertal, in which case they're too late, and we wouldn't start someone post-pubertal and pubertal suppression, because what it does is you effectively put someone into menopause. And so they would either have the option of estrogen or testosterone if they would like, and possibly surgery in the future. Next slide. There are some people who don't want either. So an example of this is I have a non-binary young person, and actually about a third of our young people identify as non-binary, who does not assign female at birth, does not want testosterone because doesn't want to be hairy. They say they just want to be like neutral. And so later down the track, they'll get a referral to discuss surgical treatment for reconstructive chest surgery, or top surgery as it's called. So looking at longitudinally, and these numbers have been replicated with our clinic and other clinics, that those who have completed, and this is an American study, a complete binary social transition, and this doesn't necessarily mean that they've had a medical transition. Most, so over 95% were still identifying as trans or non-binary. Next slide. And so there's this talk in the media around regret or detransition. We don't use detransition, we sort of use retransition, or changing one's mind versus stopping treatment. So we have people who stop treatment, but they're not regretting and they're not detransitioning. An example of this is someone who's trans masculine, who's post-pubertal. I had someone who started on testosterone, was on it for a year. They developed some of the early features like deepening of voice, increased hair, but they didn't want a full beard. They said, I didn't want to look hypermass. So they then stopped their hormones, their testosterone, and they still had their estrogen, so they still have a sex hormone about, and they thought about perhaps having top surgery later down the track. So they haven't detransitioned, they've just decided to stop treatment. So when you read papers that conflate them, just be really wary that stopping treatment doesn't mean detransitioning or regret. Next slide. And this is a survey of regret of the large Amsterdam cohort. So we're talking over nearly 7,000 people, those who've had hormones and surgery, and very, very few people actually experience regret. And a lot of it wasn't regret around their gender, but it was things around social regret, like loss of employment, rejection from family. Okay, next slide. So things that young people, trans and gender-based young people, would like you to know. And these are the 10 things. So gender and sexuality are totally different things. Talking to the strangers about this is uncomfortable, so don't expect to be able to unpack it in the first session that you meet someone. We're a bit different because people know they're coming to see us for gender. Non-binary people exist. Names, pronouns, and gender markers are important. Don't ask me about my genitals unless medically necessary. And we mostly don't examine young people's genitals. Physical examinations are uncomfortable for everyone, but especially for me. Gender-affirming hormonal interventions can save my life. Please train your staff as well. Many of us have had visits starting with the wrong tone, starting with check-in. This makes me shut down. If I'm depressed or anxious, it's not likely because I have issues with my gender identity, but because everyone else does. And lastly, let me know you're on my team. So this was a qualitative study of from a group of youths in the US. Next slide. So I might skip. I have this slide around parental support, and parental support is really, really important. It is like the single most important factor in young people's mental health, because if young people, trans and gender diverse young people, are supported and affirmed in their gender, then the rates of mental illness are comparable to those of their cisgendered peers, which is still elevated. We know adolescence is a time of, the time of the first episode of lots of mental health conditions. And the single most important factor of the good mental health outcomes is strong parental support. So it's not lukewarm, I'll support you sometimes, it's actually strong parental support. In the interest of time, I'll skip the next few slides and I can give these later around family, and I'll go to this was just to show what parents face and why it is it's important to give parents support, and there'll be a list of community supports. But the next slide, okay, this one. So what can you do no matter what setting you are? And this is for those who work psychotherapeutically, allied health as well, is just to be supportive, to treat coexisting mental health conditions, to facilitate peer support and connections for young people and their parents if they want it. So not everybody wants it, but if they want it, to be able to do that. Advocate for affirmative action at schools and in the community. So, I will pick up a phone and speak to a vice principal around young person's preference for toilets and whatever else. Family therapy or parent work, support through social affirmation. And sometimes it's like some parents think like they need to go to the gender service to allow their child to cut their hair, basically. And it's just like, you can let your child cut their hair, and then, it'll grow out if there's anything. To not be too worried about that, because parents worry about doing the wrong thing, but actually you can't make a cisgendered child trans. Like, you can tell me all you like that I'm a boy and I shouldn't have whatever else, but I will never identify as male. And use therapeutic models that you might have for other interventions. So assertive training, social anxiety, using CBT or ACT or other models. The next slide. And so these are some of the guidelines. These are available on our website for the medical people. It's got the medical information there for you. The next slide. And the World Professional Association has I think it's about 200 pages, but there's a really good chapter on children and a good chapter on adolescents as well, if you're wanting to read more around some guidelines. Next slide. So in terms of referral pathways, and this is specifically around medical care. For those who are younger than 12, when you're looking at medical care, and mostly it's pubertal suppression, really, it's only the RCH that does it, and it's partly because we subsidise it. Otherwise, it costs about $1,500 per injection. And there are very few paediatric endocrinologists who will do this. For those who are 12 to 16 and younger than 16 for medical treatment, you can refer to us, but actually there are a lot of other practitioners. So there was some funding to the Origin Transgender Diverse team, and they've got their 5 headspaces that I've listed there. So young people and families can ring the teams, those centres, and book in and see. They've got peer support, they've got mental health, and they've got prescribing GPs who will do the work. There are also other headspaces. I know the one in Frankston, there might be some other regional ones where they've got GPs who will prescribe, along with some private clinics. And for those who are 16 and above, so once you reach the 16th birthday, the referral should go to the Monash Gender Service. You can still use Origin as well, because Origin will go from 12 to 25. The other headspaces, and then the private clinics that I've listed there. There'll be more, but there are some of the ones that I know there are GPs will prescribe for those who are 16 and above. Okay, next slide. So this is our phone line for professionals, for GPs, but also allied health. It's serviced from during office hours, and it's usually our resident who picks it up. And then if they can't answer the question, they'll refer either to a medical person, a paediatrician, or or myself, one of psychiatrists. Or you have questions around referrals, you can also ring this number. And again, I'll put this on the slides. And I think that's it. I've just got a video, but we don't have to see that. If we have time later, we might. But I know you've got other things on the agenda. So I'm also happy to answer questions if there's any.
Thank you so much, Shram. Sorry, I'm just... Sorry, we might come back to questions a bit later, if that's okay. So just a quick talk around health pathways. So health pathways are written by GP clinical editors with support from local GPs, hospital-based specialists, and other subject matter experts. The purpose of health pathways is basically to reduce variation in care and how to refer to the most appropriate, hospital, community health service, or allied health service provider, and what services are available for my patient. So you can always give feedback if you disagree with one point, or you want to add to another service or something that you know of. So please feel free to send the feedback. And there are multiple different health pathways that are specifically directed at resources involving child mental health, with a few around gender diversity as well, if you have a look, and they do list resources and available support services. And since we are studying, we can also self-claim some CPDRs for that. So if you haven't really registered already, please feel free to scan this QR code, as it's